all our dear pediatricians, for all our pediatrician colleagues and students. And we have covered all the basic of congenital acquired heart diseases. And here we are going to discuss about basically arrhythmias. We have done basics of ECG reading in last talk. And this time arrhythmias, Dr. Atul is going to discuss. Atul is a pediatric cardiologist. He is there in Narayana Hridayalaya and senior pediatric cardiology. He has worked at Satyasai, Raipur. He has established the Center of Pediatric Cardiology there. Now, and he has, in addition to his pediatric cardiology training, the electrophysiology training also he has. So he is one of the expert in pediatric arrhythmias. Welcome, Dr. Vikas.
नमस्कार मैडम, हाउ आर यू?
I'm good.
आई
I'm
एम
good.
सॉरी, मैं लेट हो गया थोड़ा सा ना. We'll discuss after this meeting tonight or day after about the hands-on workshop, है ना?
Yes.
We'll discuss.
So this presentation, yeah. The Atul is the best person to talk about the arrhythmias after this basics of ECG reading. So I request Atul to start his presentation without wasting time.
Good afternoon, everybody. Thanks, Dr. Manish Tomar and Team IAP Uttar Pradesh for organizing such a great initiative. I wish I would have been in this era where we could get knowledge at the fingertips from experts. So really, it's a great initiative and I'm happy to be a part of it. And dear learners, this today's session is probably the last of your training, online training. And after knowing the normal ECGs last time with Dr. Mani, and we will discuss some cases where we'll see some rhythms which were abnormal. So so when you are faced with a abnormal rhythm ECG, most of us, when we are in our training, we would have this sort of expression. But now my job is to convert that expression into this by helping you keep calm and being confident. So we should now first see what is the mechanism of arrhythmia formation. An abnormal rhythm is a arrhythmia. So how does the arrhythmia form? There are three basic mechanisms in which an arrhythmia is formed in the heart. The first and most important mechanism is the re-entry mechanism. In a re-entry mechanism, what happens is there are two pathways which have different conducting velocities. And because of a block, a partial block or a very transient block in one of the pathway, which is the usually the slower of the pathway, what happens is the other pathway takes over, and then the pathway which got blocked starts conducting in a retrograde fashion. So this results in something which is called as a re-entry electrical loop, and which is the cause for most of our arrhythmias. And very important to understand this. The second cause of arrhythmia is increased or enhanced automaticity. Some particular focus in the heart is firing at a very fast and abnormal, physiologically high rate, resulting in a very high heart rate. And this is because of either some irritative focus or some sort of inflammation or an abnormally fast focus which is there, maybe congenitally, we don't know. So that results in enhanced automaticity, and sometimes it is triggered on by inotropes or such medications. The third form of arrhythmia is arrhythmia mechanogenesis is triggered activity. And what do you mean by triggered activity is it is working like the trigger of a gun. So when you see how the gun works, the trigger gets pulled by and at a certain pressure, it gets pushed towards the bullet, and then it fires the bullet. So similarly, there is slow depolarization occurring in the heart muscles, and that depolarization occurs so slow that it goes into goes on into after depolarization. And then suddenly, because of the slow accumulation of the ions, we have a sudden abnormal impulse, and which results after a normal heartbeat, and then that triggers the future arrhythmia. It could be a atrial tachy, or sometimes, most of the times, it is a VT. So these are the common mechanisms that we should know. The tachyarrhythmias that we generally come across in the atrium is atrial fibrillation, atrial flutter, atrial PSVT, or it comes under two. Either it is AVNRT or AVRT. Um, a special form of tachycardia called PJRT, or permanent junctional reciprocating tachycardia, which I will show one example. Atrial tachycardia, and sometimes inappropriate sinus tachycardia, or sinus tachycardia which occurring without any reason at rest. And the ventricular tachyarrhythmias are ventricular tachycardia, ventricular fibrillation, and in between the atrium and ventricule, you have the junction, and then sometimes you have junctional ectopic tachycardia. Amongst the bradyarrhythmias, either there is sinus bradycardia, you can have AV block of the three varieties. There is a first degree AV block, second degree AV block, and the third degree AV block. Then the remaining are relatively rare in pediatric age group, which is sinus arrest, or sick sinus syndrome, and sinoatrial exit block. So these are very rare and difficult, and not really seen much in normal children. From a pediatrician point of view, what are the things that you should look for when you come across a patient with tachycardia? So first of all, you see whether they have symptoms or not. The child could be asymptomatic. They could have syncope, palpitation. Sometimes they complain of chest pain, or they cannot explain whether it is what is happening to them. So they complain of chest pain or chest discomfort, and sometimes they call it as dyspnea, or a difficulty to breathe, or suffocation. So these are the common symptoms that they come with. Um, we have to see whether it is a first occurrence or a recurrent occurrence. We have to see what situation it occurred. Did it occur at rest, or after exercise, or in emotional circumstance with anger or fright, or occurred during sleep or after awakening from sleep, and also whether there was associated with post arrhythmia micturition. Coming to the onset, we have to see whether the onset was gradual or the onset was rapid. Similarly, we also see the termination, whether the termination was gradual or rapid or sudden, as if suddenly the patient started feeling normal, something was happening and suddenly they started feeling normal, or it gradually reduced. Because we can diagnose what kind of arrhythmia it is based on the onset and offset. Uh, Sometimes the termination, the patient could say that I had a vomiting, which is suggestive of a vagal maneuver or vagal activity. So vomiting or gagging, which resulted in termination. So all these things also you can um, look for or ask. From a pharmacological perspective, we have to look for whether any antiarrhythmics, any cardiac stimulants, antibiotics, or any accidental overdose of any medications has been done. Look for family history of arrhythmias, sudden cardiac death, and such events. And most importantly, where the child has a structural heart disease or not, is also important to understand what is the arrhythmia and what is the prognosis. So coming to our first case, um, a 8-year-old boy who presented to the emergency with history of palpitations and chest tightness since 1 hour, and he says that he has had this uh, previously, but had lasted shorter episodes, like for a short duration only. But this time it has lasted long, and he's quite distressed by it. So the ECG was done, which showed this. And when we come across such a ECG with palpitations, we will see what exactly is the okay. So we'll see what exactly is happening. You see, have a look at this ECG for 10 seconds, and then I'll just go to the next slide. Do we have a one-to-one? Do we have an interactive this thing on the chat where anybody can either type or anybody's watching?
Yeah, I will request all attendees. You can just write what is the heart rate, QRS narrow or
Yeah,
wide, like regular or irregular. So you can answer in these points actually.
yeah, yeah. I'll go to the next slide. That is actually the thing. So in this, what we see, first of all, we see is this really fast or is it slow? So it's fast, definitely. What is the heart rate? And we go by the usual heart rate measurements of uh, so you see here it's less than two small squares, sorry, large squares. So it's about 150 or slightly more than 150. Then is it normally fast or abnormally fast? For an 8-year-old boy, it is abnormally fast to have a heart rate of above 150 or 160 at rest. When he's having symptoms, somebody who has run the distance and feeling a fast heart rate, it will settle down. But when somebody is at rest and the heart rate is going that fast, they will feel the symptoms and they will come with that. So all these symptoms should not be neglected at all. Whether that QRS is narrow or wide, and whether the QRS is coming regularly or irregularly. So going back to the slide here, the QRS is fairly regular and it is narrow because it is just around two small squares, two just about maximum three, but looks like small squares. So it is a narrow QRS tachycardia with regular RR intervals. Okay. So in such a case, when you have obviously the diagnosis is either sinus tachycardia or a SVT, but there is no P wave coming before the QRS complexes. So watch where the P wave is. You can't see a P wave really before the QRS complex. And this is not a P wave here. Okay. So what we are seeing is a retrograde P wave coming here. Okay. And then in V1, you can see some slurring here where my pointer is. So those are the P waves. So it is a retrograde P wave suggesting it is a SVT. It's not a sinus tachycardia. And hence, so see in another such a tracing, you can see that there is a P wave in the buried just after the QRS complex. So I tried to zoom it up, but it's not very clear in this one. So, but you should be able to identify the retrograde P wave in a rhythm of SVT. And so what do we do? Now, this was AV nodal re-entry tachycardia or AVNRT. So it is one of the commonest supraventricular tachycardia. Um, and you see that it occurs due to two pathways converging into the AV node. There is uh, a pathway which comes from the sinus node which is faster than the other pathway. So that gets named as the fast pathway and the other gets named as the slow pathway. So having two pathways is called as dual AV node physiology, which is there in almost 50% of our population. But everybody doesn't develop a SVT or a AVNRT. So the AVNRT develops only when there is significant gap in the conducting velocities of the two pathways. Okay, and that gap has to be such that extra beat can come or get accommodated within within the gap between the two pathways. So that is called as a critical interval. And only when say certain situation arises, like either the pathways get old and degenerated, or if there is some excessive stimulation by inotropic agents, then you may have a AVNRT due to the presence of the two pathways. So um, when we are faced with a narrow complex tachycardia, the first thing that you should see after we have seen the basics is where is the P wave? No, the P wave coming before the QRS, or is the P wave coming after the QRS? When the P wave comes immediately after the QRS, it is called a short RP tachycardia. And examples of short RP tachycardia are AVNRT that I showed you, and AVRT, that is atrioventricular reentrant tachycardia, which occurs with a accessory pathway. When the P wave comes in front of the QRS complex, it is called as long RP tachycardia because it is long as compared to the previous QRS. It is the short and the long is as per the previous QRS. So this is a short QRS and this is a long, short RP from the QRS, and this is a long RP from the QRS. So short and long RP, you should see the examples of long RP tachycardia are atrial tachycardia, even sinus tachycardia, atrial tachycardia, flutter, fibrillation. In fact, fibrillation you don't get to see much P waves, but flutter, fibrillation, and atypical form of AVNRT are some examples of long RP tachycardia. The most common you will get is either AVRT, that is atrioventricular reentrant tachycardia, or AV node reentrant tachycardia. These are the two common PSVTs, and more or less they have the same mechanism, except that the circuit of a AVNRT lies only within the AV node here. Okay, and the AVRT circuit involves an accessory pathway. So the AVRT circuit lies in a much larger part of the cardiac muscle. It could be on the left lateral side, so you may have a macro sort of a re-entry circuit, and the AVNRT circuit is only localized to around the AV node area, so it is a micro re-entry circuit. Can see from the sinus node to the AV node, we have two pathways, and then that results in the AVNRT. You can see the pseudo so the retrograde P waves in the end of the QRS. So how do you manage such a patient who comes to you? So after seeing the basic parameters, uh, we can try the vagal maneuvers. And what are the vagal maneuvers? It could be carotid massage, carotid artery massage. Could be applying a plastic bag with ice and water to the face for 10 seconds, or it could be inducing a gag by oropharyngeal suctioning or with a spatula. All these vagotonic maneuvers, basically what they do is they uh, create intense vagal activity on the AV node and tries to reduce the conductivity of the AV node. When the AV node is conductivity is reduced, or it gets blocked for even a half a second, sometimes these tachycardias break because AV node is a part of the circuit which is created during the tachycardia. And all these vagal maneuvers also should be done under continuous ECG monitoring for us to see what is happening during the maneuver. And in a study done to see what kind of which maneuvers work the best, it was found that ice to the face is probably one of the better maneuvers than any other. And after that, the adenosine was given. It was successful in remaining 56%. Um, and in those who were not successful, again, a second dose of adenosine was given, where it was successful in another 50% of the not non-responders to the first adenosine dose. So we have to know now why people don't respond to adenosine. So adenosine is commonly used drug for SVT. It has a rapid action and a very short half-life. We all know that. How it acts on the heart is it blocks the AV node conduction and also the conduction of the surrounding tissue around the node. It terminates the tachycardia by breaking the circuits by inducing and sustaining the AV block. But um, but the tachycardias who are reentrant only respond to adenosine. The ones which have automatic foci do not respond because they will temporarily suppress the AV node, and then again once the suppression goes away, the tachycardia, the AV node will start conducting the tachycardia across it. So we have to know that this adenosine response is that of sudden reversion to sinus rhythm. It is not that it slows down and then picks up. Is not adenosine response. We cannot call it as adenosine responded, but it reverted again. So revert when it reverts means adenosine has to stop the tachycardia. If it does not stop the tachycardia, you have to give one more dose of adenosine. If it does not respond to the second dose, the third thing is to cardiovert in the acute setting.
Atul, here just one small question. When we repeat the dose, do we need to increase the dose or same dose?
Increase the dose, yes,
Yeah,
because
so double.
the time taken to reach the heart might have been reduced due to maybe poor circulation or even the size of the patient and where the IV line has been placed. So we can increase the dose actually.
And when we were seeing that tachycardia, so means for the learners, they can increase the speed of ECG to look at
To,
the to
yes,
try
yes,
to look at the P wave if like it's 200 plus heart rate, it is difficult to see the intervals. So they
yes, yes.
can increase the speed of the ECG
Sure, sure, ma'am. Yeah,
recording.
that's a good point. Actually, when it's in where the tachycardia is so much that you are not able to make out the P waves, you can increase the speed to 50 millimeter per second and try to see, and also the amplitude to see if you can see the P waves in that. While giving adenosine, again, continuous ECG monitoring is necessary for you to see what was the response before, what is the response during the adenosine, and what is the response after the adenosine. So many people or many residents, what they do is before adenosine they document SVT, and after adenosine they document sinus rhythm. But what happens during adenosine is not shown. So it is important to do continuous ECG monitoring or
नहीं
recording
नहीं,
and
वो तो
adenosine.
बोल भी रही थी। मैं चाहूँ तो करवा देता हूँ।
Uh, Dr. Ali, please mute yourself.
So with adenosine, we have to also be slightly careful of exacerbation of asthma. And we also know that diagnostic significance of atrial flutter by unmasking the flutter waves in the ECG.
इजहार कह रहा था कि उसमें बच्चे को ले जाना होता है, बच्चे को लाना होता है, कहते आपकी ऐसे
Sir,
हालत है।
Dr. Manzir sir, please mute yourself.
रख देंगे,
इसको छोड़ो।
देखते हैं, नहीं तो हम रुका करेंगे। वो जब तक जाएंगे तो हम रुक जाएंगे, कोई प्रॉब्लम नहीं है।
Tapan, please call and Yeah, then you
Okay.
can continue.
Yeah. So, so that's with adenosine. And this is what happens when we do a continuous monitoring, continuous recording with adenosine. There's a SVT which is going on, and adenosine sort of hits in this area, and we get a complete block for some time where the P waves is not um, transmitted, and then we have some activity which comes off maybe with a bundle branch block, and then the sinus node takes over with a narrow QRS, and you have normalcy after that. So another case, so 18-year-old girl who has exertional breathlessness. On examination, she's pale, clammy, and chest X-ray shows cardiomegaly, and echo is showing ejection fraction of 30%. So she has LV dysfunction, and she comes with nausea, vomiting, and dizziness. So her heart rate is, her ECG is this, and the heart rate is around 130 to 150. It's a bit varying. The ECG is showing this. So how will you analyze this ECG here? The, so in this ECG, we can see that QRS is a bit irregular. It is narrow, but it is irregular. You can see in between the two QRSs, you can see some not really P waves, but they are atrial activity waves. I refrain from calling them P waves because they don't look like regular normal morphology P waves. They are a bit pointed. They are sort of biphasic and spread out throughout without any conduction. So this is not
Uh,
a case of heart block. This is a heart block induced by the tachycardia. Okay.
Atul, just a small interruption. There is a query related to previous ECG.
Yeah.
Doctor is asking if it is not by two adenosine doses, if it is not reverting, can we give metoprolol?
We can give metoprolol, try to reduce the sympathetic tone, and try adenosine again
And if
after
patient is
that.
hemodynamically not stable,
Hemodynamic
then
is
better
stable,
to
we can give
cardiovert.
metoprolol. Yes.
Uh,
When hemodynamically unstable, we have to cardiovert.
Cardiovert.
And here in this ECG, we can see that we have these pointy sort of waves, which are the atrial activity waves. So all of them are not conducted to the ventricle, but they are occurring in bursts. Okay, so because of that, we are having an irregularity of the rhythm. So this was a case of atrial tachycardia with tachycardiomyopathy, which is many times missed when we are looking at LV dysfunction or cardiomyopathy. And the key to diagnosing a tachycardiomyopathy is you have a constant heart rate throughout the day. If you do a Holter, you'll not see a variation or a diurnal variation of the heart rate. And if you see that, always the atrial tachycardia will never be in the high 200s range. They will be sometimes they will be in the 150, 170 range, and it will stay like that throughout the 24 hours, even when sleeping or even when resting. So that is a sign that okay, you should suspect that there is a incessant tachycardia going on, which causes the tachycardiomyopathy. So in atrial tachycardia, you see a different morphology P waves. The rhythm can be regular or irregular. In the regular ones, it could still look like your SVT of the previous the previous example. And here in the atrial tachycardia, you may have a block pattern, but it is not a true block because the AV node is trying to protect the ventricle from the excessive stimulation by the atria. Hence, you have a variable block. Again, for atrial tachycardia, we could try vagal maneuvers. Not most of them, though, will not respond to that. But at the time of presentation, you will not be able to know whether it's a If it's a regular SVT, you will not be able to know whether it's a responsive to vagal or not. Hence, all the regular SVTs, you should still go for vagal maneuvers if they are hemodynamically stable. In the meantime, try to get a IV line and give adenosine. If the adenosine is not working, again beta blockers. And but if the patient is unstable, then beta blockers or any even calcium channel blockers in the older patients. We avoid giving calcium channel blockers in the infant age group. And if they are unstable, we go for cardioversion. Um, so these are the various classes of antiarrhythmic drugs which are available. And coming to another case, do we have any question on the previous case?
No, Atul, no.
Okay. So another young child, around 20-year-old with history of rheumatic mitral stenosis and has long-standing recurrent palpitation, which are lasting more than 6 to 7 hours. And ECG was done, and it showed this rhythm. And again, we see that the rhythm is quite fast and going at 150, but it is irregular. You have some speeding up here and then slowing down and further slow and then further fast. So there is a change in the um, this thing. Rate and rhythm and also the morphology, because sometimes you see a narrow complex, sometimes you see a wide complex. So this is a case of atrial fibrillation. And when you see the narrow and the wide complex, it is basically aberrancy. Aberrancy means temporary refractoriness worsening with increasing heart rate. So when the heart rate suddenly increases, the conduction system takes a while to pick up with the heart rate. And the initial few beats could be a bit wide or bundle branch block. So that is called as aberrancy. And in atrial fibrillation, when the aberrancy occurs, it is called as Ashman phenomenon, and it is characterized by short, long, and short sequences. And aberrancy is seen in most of these automatic tachycardias, which are excessively fast. Um, Automatic supraventricular tachycardia, which are excessively fast and make it look like VT at times. So one of the most common differential of a wide complex tachycardia apart from VT is SVT with aberrancy. Um, then the one more case of an adolescent boy who presented with dizziness, chest comfort. This was his first episode, and ECG was done. Now, this is a bit different ECG, and I would like you to just please be careful, carefully look at the waves here. I will go with it one by one. So here you see lead 2 on this long strip. It's very important. You get to see these fast QRS complexes, which look a bit narrowish, but then we have one which is narrower than this. Right? One bit which is narrower than this. And then again you have this, okay, which goes on till the end of the strip. So what is this beat? So this beat is actually a sinus beat which occurred in what is looking like narrow complex, but actually wide complex tachycardia. And if you see the lead V1, there is notched QRS complex there, which is in the M pattern. suggesting right bundle branch morphology. Okay, so we have here a, wide complex tachycardia with a narrow capture beat and a right bundle branch block pattern in the precordial lead. So the bundle branch pattern, we should know that whenever there is a right bundle branch, okay, so this is actually VT. Okay, so what kind of VT it is something we have to see next. Whenever there is a right bundle branch block pattern in the precordial leads, that VT is actually coming from the left side, so left ventricle, and vice versa for the left bundle branch pattern. Whenever there is a left bundle branch pattern, the VT is coming from the right side. So if there is a discordance in the bundle branch pattern versus the where the origin of the tachycardia is. Okay. Again, Dr. Mani has last time told you how to determine the axis of the heart. So here we see the lead one is more or less equiphasic, equal R and equal S, but the AVL is strongly positive and AVF is fairly negative. So it is like a left axis deviation with left axis deviation with a right bundle branch block pattern. And this presentation is characteristic of what we know as fascicular VT or Bell-Hassen's tachycardia. And it's a very important to know this, because many times we would fail to identify this as a VT. So ECG interpretation, we look at QRS duration in this ECG, whether it is SVT or VT. Is there a bundle branch block pattern? And if yes, whether it is right ventricular or left ventricular bundle branch. What is the axis, whether it is right axis or left axis? And in fascicular VT, the re-entry occurs between the two fascicles of the left ventricle, the posterior fascicle and the anterior fascicle. So the re-entry circuit is lower down, lower below the AV node. Hence, it is a VT. Okay. Typically, with fascicular VT, we describe it as narrow but not really narrow, and broad but not really broad. So if you see this, that's why there is a confusion whether this is SVT or VT, because it is close to the natural conduction system. That's why it makes it appear narrowish, but not really narrow. And the you saw the capture beat, it gives away that diagnosis that this is a VT. So but this fascicular VT is the form which is extremely sensitive to calcium channel blockers. Hence, it is also known as verapamil sensitive VT. It will not respond to adenosine. It will not respond to beta blocker or amiodarone, and only the rate control will be there. Rhythm control may not be achieved. So, but it is so sensitive to verapamil that once you start infusing verapamil, by the time the infusion gets over, the VT would have responded to sinus rhythm. And in hemodynamically affected patients, we can always shock them out. But it is important to identify, because your treatment relies heavily on your diagnosis. So just be wary of all these. Just remember this pattern, M pattern in V1 and discordant pattern of AVL, AVF. That is AVL looking up, AVF looking down, and V1 showing a bundle branch block pattern. This is very typical of fascicular VT. So after all these examples, what do we do? We have identified the arrhythmia, we have treated with the antiarrhythmics, we have treated acutely as well as managed the medium term. But some arrhythmias are going to come back again. Whether you are giving medications, it will remain controlled, but one day it will break through. So the eventual treatment of most of these arrhythmias is EP study and ablation with radio frequency. I will not go into too much details, but what we generally do is we put in some special catheters in the various parts of the heart, the right atrium, right ventricle, and approximately in the bundle of his and coronary sinus. And we try to see what the arrhythmia, where it is arising from, and go there and give the ablation lesions. So that is what is EP study about, and which we use to treat these arrhythmias as a final cure. Coming to the next set of arrhythmias, now this is another subset. So for a young man starts feeling dizzy during a 3 kilometer run, and he faints. And during that marathon, there are some paramedics on the scene. So they quickly rush to the scene. They find that he is in VF, and they administer CPR and shock him out. So this was the first episode, and no such events amongst the family members. So when this paramedico reached, they saw that this was the rhythm when they had put on the defib rhythm strip, and this was the rhythm. So what has happened from here to here? We can see there is a different morphology of QRS every time. It is very disorganized. It has notches. It is wide complex. Plus, what is very typical is one of the QRS is looking down, that is negative. Another is looking up. Third one is sort of not really committed to either down or up, but somewhere along here you get a negative, positive, negative, positive, negative, positive type of a pattern. So this is wide, complex, irregular, polymorphic VT, and then it goes and degenerates into VF towards the end of the strip, and that's when they shocked. So this is very typical of something called as CPVT or catecholaminergic polymorphic VT. So we'll go to take this term one by one. Catecholaminergic means it is responsive to catecholamines, that is endogenous adrenaline or noradrenaline. Polymorphic means it has multiform QRSs. And it is very specifically characterized by bidirectional VT. You saw that there is a positive, negative pattern. This is called as bidirectional VT, and it is typically seen with either digoxin toxicity or with CPVT, only two diagnoses. As the heart rate will increase, the physical activity and catecholamine surge in the body can trigger a VT. Similarly, I have had one patient who was in the who had gone to a fair, and he was in that turning wheel, and he was coming down. It was triggering that emotional stress in the body, and it triggered off VT. And when the wheel stopped, he was found to be unresponsive. He was immediately taken off and administered CPR. So it can happen during such events also, even in say amusement parks or any other places. So mutation of the ryanodine receptor gene is autosomal dominant, and it is the one which is responsible for this CPVT.
Atul, just a small interruption related to previous case. I just saw the message.
Yeah.
Dr. Annamalai, she like RSR respirator with left axis deviation. So just to correct that, it will be in ostium primum ASD, not in ostium secundum, but a good point from her side. So obviously, but we are talking about the tachycardia here, not
Yeah,
the
yeah.
stable
And
rhythm. We are,
and
yeah.
RSR, it is a partial incomplete RSR pattern
Hmm.
or incomplete right bundle branch block with a left axis deviation, and you have a normal P wave preceding every QRSS,
Yeah.
whereas in
So
VT it will be different.
yeah. So sinus rhythm with the right bundle branch block with the left axis deviation, that is ASD, ostium primum, means AV canal defect we are talking about. But here it is the arrhythmia, tachycardia, which is going on. So which we. And in this CPVT, Atul, just to clarify, what will be the baseline rhythm when patient is not tachycardia? Can we make out on anything on that?
No, unfortunately, they will be absolutely normal sinus rhythm.
Yeah,
They will not
yeah,
be able to
that's
find out. So these are things which can occur as a sudden cardiac death without us
yes,
knowing
yeah.
what
That's
what.
why so many event happened. Like in school, recently a child expired very recently, in third or fourth standard. So this type of thing could be the cause
Yeah,
of
yes. Most of
sudden.
the sudden cardiac deaths should be investigated thoroughly
Yeah,
and within the family also.
yeah.
And
Family,
nowadays,
yeah, family screening should be, yes. Yeah.
genetic screening is so easy, widely available. We should, as pediatric cardiologists as well as pediatrician, we should make use of it and counsel our patient to go ahead. Many times, what happens, patient come to us and we advise, but then they go back to their referring pediatrician. So some of the pediatrician, especially the senior ones, feel what is the need for all this. But in reality, we should change with the changing times and try to give a complete diagnosis, even if it is of academic interest. Sometimes it is of like nowadays we have primary prevention for such events, and then these things could be avoided in the families. So
True, true.
Dr. Atul, uh,
yeah.
good
Hello,
afternoon. This is
Maitri.
Dr. Maitri.
Hi, Dr. Maitri. How are you?
Hi, I'm fine. I just wanted to know for this, like people who are
Hmm.
participating in marathons and all, before that, can we do a treadmill test in the real speed and all and see that whether we can induce a VT or it will not help?
If there is a history of any other problem, then we can, but otherwise it's difficult, right? So to stop people from um,
Pre-sports participation, you
yeah,
will not
pre-class.
advise
This
this.
is not sports participation, yeah, but yes, but pre-sports or competitive sports participation is quite necessary. In India, we are not doing it to that extent, uh, and also it cannot be done for the general population simply because of the volume of this. Otherwise, um, we could have, but those who have structural heart disease or some family problems should definitely undergo some form of TMT to see what happens. So TMT should not be only restricted to ischemic heart disease, but also for finding out any arrhythmias. And hello, am I audible?
Yes, yes.
Yeah,
Yes,
yeah,
yes. Thank you.
and since we have pediatricians here also, and you have raised the question about sports participation, all these kids go to the pediatrician for certification of sports participation, and it is not customary in our country to do a complete cardiology review, and most of the times it is eyes, muscular, and just auscultation, and then they are given certification. So I think it is better if the pediatricians take uh, the modern way of thinking now and probably take up a complete cardiology evaluation at least for sports participation, because it could have litigational effects later on, that he was certified, completely normal, but he was having a hypertrophic cardiomyopathy and then passed away due to some VT. So it's better that all pediatricians should, at least those who are desirous of joining competitive sports, should undergo sports pre-participation evaluation. which includes at least a TMT, ECG, and a echo.
Correct.
Dr. Atul, good afternoon.
Good afternoon.
Yeah, myself, Dr. Leena Dhande. I was with you in IGMC.
Yeah, madam.
Yes, sir. Yeah, one question. Just like you told about persons interested in going, like kids interested in going for competitive sports, we should be doing a TMT, ECO, and ECG. Similarly, we have to give this pre-anesthetic evaluation. We have to evaluate them. So in that situation, should like eco be made mandatory for every child undergoing any procedure?
Any procedure, sorry, ma'am? Procedure as in?
Surgical procedure, sorry.
Surgical procedure.
Yeah.
It's difficult to again do, but then if it is done for all the adults, we can probably consider if there is a strong uh, suspicion by the pediatrician. But most of the adults do have echo for pre-procedural evaluation. But if the procedure is high risk or carries some risk of like um, prolonged procedural time and all, anesthesia risk, if they want to rule out, I think we can consider for echo before that. But most of these, at least a ECG should be done, if not an echo. An
Yeah,
ECG should
sure.
be evaluated by a pediatric cardiologist.
And ECG should be compulsory. Means all pre-anesthetic workup, like any clearance, any certification. I think ECG is a very basic test and should be advised when we are giving a certificate of so-called fitness. If indicated on that, we can decide about to go for echo or not. If it is like ECGs should be used more frequently in pediatric practice.
Yeah. Yeah. And just for the record, everybody, like Dr. Lina Madam who just asked the question, she's actually my guide and my head of department when I was working in my pediatrics. So it's quite humble question by her, and really feel nice
Great.
to answer
Thank you, Dr.
that.
Lina, for being here.
Oh, it's my pleasure and it's a pride to hear, Atul. God bless you, all of you. Thank you.
So, in coming to case 6, this is a asymptomatic person whose brother had a sudden cardiac arrest recently. So he came for an evaluation, and this is what we were discussing, that this was noted on his ECG. And is there anything abnormal seen? So it looks like normal sinus rhythm, normal complexes, um, normal intervals, PR interval, QRS. Um, so we look at QTC interval now, and just for all the students, the QTC interval, if you don't want to calculate, at least look at where the T is ending. And if the T is ending before the midpoint of the RR interval, you are safe. But if the T is ending somewhere in the borderline, it's better that you manually calculate it. The QTC is calculated how? By finding the Q wave. So find the best complex with the Q wave. Sometimes it is lead 2 or 1 or V5, and you see the Q wave after the P wave. From the Q to the end of T, you find the QT interval and divide it by the RR interval, which is the previous RR interval, not the next RR interval. So QTC is thus calculated, and um, then we find out whether it is prolonged or not. But in this case, you see a slightly different pattern in V1, V2, and you see the dome and spike and dome and coving pattern here, V1 and V2. This is very typical of Brugada syndrome. And Brugada syndrome is also one of the important channelopathies where you get sudden cardiac death in the families. Again, because of lack of too much like less investigation in form of ECG. We don't know what is the real incidence in the country, but we with more and more awareness, we are definitely finding more patients, even in children coming with Brugada. And interestingly, Brugada syndrome children sometimes have absolutely normal ECG. The Brugada wave comes off in times of fever or during stress. So again, if we see this pattern during fever, it is a sign that this child or the family has some channelopathy, and we have to investigate further. So it's very important to see this or identify this pattern in V1 and V2, slightly like a ST elevation and then depression. ST elevation, depression. The spike and spike or the dome and the coving pattern. Okay. So these are three types of Brugadas that we, type 1, type 2, which we saw, and type 3. So, another young child who had recurrent seizure-like episodes and was on multiple anti-epileptics, but seizures continued. And he was further referred for a cardiology evaluation by the neurologist. We performed a Holter, and in the Holter, during one of the episode, we saw this. Now, this is a very classical example, and we know it, we have seen it and read about it in the books. So this patient had congenital long QT syndrome, polymorphic VT, and Torsades-Duponts. So what is Torsades? Torsades is basically polymorphic VT, where the VT axis changes at the points. So if from the VT axis comes to 0 and then changes to opposite direction, and then comes back to 0 here and then changes to the like flips by 180 degrees again. So this is called as torsades du point or twisting of the points. And on genetic study, we found that there was KCNQ1 mutation. So KCNQ1 mutation is pathognomonic for long QT type 1. And commoner mutations which are associated with congenital long QT syndrome is KCNQ1, KCNH2, and SCN or sodium channel 5A mutation. So these stand for long QT1, long QT2, and long QT3 subsets, which almost goes to 85 to 90% of all the long QTs. There are isolated more of long QT syndromes, but they are very rare, and they have been reported in families with a certain specific mutation. So what is long QT syndrome or congenital long QT syndrome? When the QTC is prolonged more than 450 milliseconds, and it is due to a genetic mutation which affects the sodium and the calcium channels. In a predisposed person, drugs like TCAs, tricyclic antidepressant, or haloperidol, or antihistaminic drugs can prolong it further. Even antiarrhythmics can prolong it further. Electrolytes like hypokalemia and hypocalcemia also cause prolonged QTC. So in the predisposed person, it can further worsen the existing QTC, and also presence of a structural or ischemic heart disease. There are criteria to diagnose, which comes under Schwartz criteria. And why it is important to know about congenital long QT syndrome is because it is its main, sometimes its first presentation could be sudden cardiac arrest. And then we have to diagnose it for the rest of the family. So sudden cardiac arrest, sudden cardiac death, is known to occur in long QT syndromes, and we can prevent or reduce the incidence by beta blocker therapy, sympathectomy, and finally ICD or implantable cardioverter defibrillator in those who are not responding to beta blockade and at high risk for sudden cardiac arrest. So this is how I showed you how to calculate the QTC, and we saw, like, we have to see that we have to see the RR interval and whether the T wave is falling before the midpoint of the RR interval. So so case number 8, we had this young lady who had increasing breathlessness, chest X-ray, again cardiomegaly, structurally normal heart, dilated cardiomyopathy, EF 25%, and um, this was the ECG. Now, in the previous patient with the tachycardiomyopathy, um, the rhythm was irregular, but this is a regular rhythm, and you see narrow complex tachycardia, 150 heart rate, but when we see other axis and everything is fairly normal. Are you seeing the P waves? I would say yes, because we are seeing some inverted P waves here. You can see in lead 2, 3 and AVF, inverted P waves. The rest of the P waves sort of very close to um, the QRS complexes, but not like usual positive P waves. So um, in this, I would suspect a sort of an incessant tachycardia. Why? Because the heart rate is not very high, it is narrow complex, and it has presented with LV dysfunction. So this is again a case of tachycardiomyopathy, but here the reason is you see the abnormal P waves, the inverted P waves. This was a case of PJRT, or we call it permanent junctional reentrant tachycardia. It is a reentrant tachycardia. There is a slow pathway, there is a fast pathway. But it is a quite a unusual kind of a tachycardia because it does not respond to adenosine. It is the only reentrant tachycardia which does not respond to adenosine, and then we have to treat it by rate control, and further we have to do the RF ablation of the accessory pathway. But many times we are not sure whether it is a atrial tachycardia or a PJRT, but we have to differentiate it in the cath lab with certain maneuvers. So this was PJRT. The reason I put those is because many times the LV dysfunction is considered as myocarditis, and no real opinion is taken to see whether really it is, myocarditis or is related to some arrhythmia. So unless we should look for arrhythmias, most of these patients with ventricular dysfunction, and we would probably feel that we might find more and more patients with arrhythmia, which is a treatable condition, rather than myocarditis leading to LV dysfunction, which is not a really treatable condition. It may improve on its own, or it may not improve may not improve and go for transplant. So before a patient goes for transplant, it's better to make sure that he doesn't have an arrhythmia. Any questions so far on this?
No, there is no more question. We can take one more case. That's
Okay. So then we have this 10-day-old newborn, and this is again a common scenario for all pediatricians with poor feeding, lethargy, tachycardia, and they saw that there was some tachycardia, not really diagnosed what, and they started one antiarrhythmic, no response. They gave adenosine, no response. Then they started the second antiarrhythmics, no response, and they did the ECG, and And this was the ECG. Very fast heart rate, almost like 250, 270, narrow complex. And since it's a newborn, the narrow complex is very narrow. It's almost like within one square, you have the entire QRS complex. So we really would feel that, okay, this is a very fast tachy, but I'm not able to see a P wave. I am not able to see what is happening there. Already the patient is on multiple antiarrhythmics. Adenosine is not responsive. So we thought we'll still give adenosine to see what is happening. And when adenosine was given, the AV node got blocked by the effect of adenosine. And what we saw was these waves, which are tall sawtooth pattern in between the two QRS complexes. Okay, and then our diagnosis was clear that this is atrial flutter, and this atrial flutter was there congenitally in fetal life, and then when the baby was born, the heart rate was high, and in spite of that, the atrial flutter was undiagnosed. It was just because you see the AV node is so high, an AV node in the baby is so able to conduct high velocity at a very high velocity that it will almost transmit every atrial activity that occurs. So we were not able to identify whether it's a flutter or what kind of a rhythm it is. When the adenosine was given, then the diagnosis became clear. So adenosine also has diagnostic importance. So after we saw that, we shocked the baby out of atrial flutter. So once the shock was given, baby reverted to sinus rhythm, and there was resumption of sinus rhythm, and there was no recurrence of the atrial flutter at all. So it has a very good prognosis. As far as how do you identify atrial flutter in a newborn? The atrial rate is very high. The ventricular rate may depend on how much the AV node is transmitting. The rhythm is atrial on the atrial surface. The rhythm is regular. On the ventricular side, it is regular if it follows the atrium, but it may be irregular if it is blocked. The P waves, normal P waves are absent, but the flutter waves or the sawtooth pattern may be seen. Um, PR interval is not measurable, and all the QRS complexes are very narrow, and they look fairly monotonous and regular. So these are some of the steps to identify atrial flutter. In children or in newborns, you will not be able to see the sawtooth pattern unless you give the adenosine. So this is one more case, but we have any questions?
No question. There was one related to what genetic testing you advise in arrhythmias. So this was the question in previous case.
No specific we just ask for the exome sequencing for the cardiac panel. If you want particularly for cardiac, but otherwise we just ask for, they will look for all these channelopathies, whatever are documented. If they find something then which is not documented, they will call it as a variant of unknown significance. Then we have to take it into clinical context and see, compare it with the family. But to be honest with you, most of these channelopathies do not have a very set presentation. Very rarely you will really get the classical book picture, but there is some overlap. Yeah, there could be overlap between one sodium channel and another, or one potassium channel and another. There could be overlap between one syndrome and another. So you could have a Brugada syndrome overlapping with a long QT syndrome. So there is some gray area in those, but eventually our management depends on primary prevention of sudden cardiac arrest, second by either medications, sympathectomy, and ICD. And only if it is a sodium channel versus a potassium channel problem, then we can consider mexiletine for sodium channel problems, and our beta blockers mostly for the potassium channel problems. Okay,
Okay.
so this is a young man who came with SVT in with a um, tachycardia presented to the ER, and this was the ECG. And anybody would say that this is a wide complex ECG, and wide QRS ECG, this is VT. Okay, uh, and I would say most of us would be right in diagnosing it as VT and cardioverting it. But here, because we are in an academic session, this is a case of WPW syndrome with a antidromic tachycardia. Now, antidromic means against the current of the normal conduction system, and orthodromic means along the current of the normal conduction system. Here we have the tachycardia going along the accessory pathway and then retrograde through the AV node, which is why you have a broad complex, because there is slurring in there is slurring here in the um, upstroke of the QRS. If you see the V1 to V6, V1 is positive, V6 is negative, and you have precordial transition in the V4 to V5, which is looking like a normal transition. And when the adenosine was given, this patient had this appearance on the ECG, where you see the short PR interval, the slurring on the upstroke of QRS. You can see the slurring here better. And please keep this pattern in your mind, and you should be able to diagnose this whenever you come across this sort of a ECG pattern. So short PR, so P is finishing here, and immediately the QRS starts. And the start of the QRS, the initial two small squares, there is a slur. Okay, so this is a WPW pattern, Wolf Parkinson White pattern, and this is seen with accessory pathways which have a capacity to go antigrade. Most of the accessory pathways are retrograde only pathways. I would say 60% are retrograde only pathways. Only 30 to 40% are also have antigrade conduction properties, which results in this for this type of ECG. This is the only picture of these three great gentlemen standing together with the WPW pattern. Okay. So I think this is the last case, and this is a 6-year-old who presented with history of frequent fainting on exertion, and the ECG showed bradycardia like this. And this is a very classical bradycardia picture with many A waves or P waves and one wide complex um, QRS complex, and then again we have many A or P waves and then one QRS. So this is extreme bradycardia, and that probably results in syncope because of a long pause. And this is a case of complete heart block. Now, in a small child, a complete heart block is probably congenital complete heart block. A second commoner causes is post-operative complete heart block, and sometimes it is also related to autoimmune complete heart block. So this was treated with a pacemaker, and there are two ways of putting a pacemaker. In a small child, we will put it on the apex of the heart from outside, which is called as epicardial pacemaker. And in an older child, around more than 20 kgs or so, we can put it in the put the pacemaker inside the heart, called as transvenous or endocardial pacemaker, and it is put in the infraclavicular fossa. This is how a pacemaker looks with the pacemaker battery, the connections, and this is the lead. This part of the lead is inserted into this connection. And just to make everybody aware of what kind of pacing we are dealing with nowadays. So originally the pacing was done in the RV apex, or slowly it changed to RV epicoseptal, slightly septal from the RV apex, to get a good stable position and to get a narrowish QRS complex rather than a wide QRS complex, because wide QRS complex results in cardiac dysynchrony and results in LV dysfunction in the future. So they changed from RV apex to RV septum, and then after that the concept of His bundle pacing came, when they started pacing the His bundle and the area around the His bundle to get a more natural looking QRS complexes, thus reducing the chance of having a LV dysfunction or dysynchrony in the future. From the His bundle, we have moved to now left bundle area pacing, because His bundle is a bit higher. It is difficult to reach, and it is easier to reach the left bundle area to get the exact place. And left bundle branch is actually like a fan, so it has, you get a bigger area where you can pace. And His bundle is very localized, so it is located at a very certain, very focal point in the heart, as against the left bundle branch. So it is easier to get the left bundle potential and put the lead in that point to get a narrow and a more physiologically correct QRS complexes. So we are moving more towards putting left bundle area pacing. And nowadays, the concept of leadless pacing is also come, where a small capsule-like pacemaker is placed inside the heart. But in those who do not have a good and a reliable IV or a venous access, it is not done for cosmetic purpose. It is only done when there is no venous access or any like a complex heart problem with a, say, a Glenn procedure has been done and we don't have access from the top. We can either do epicardial pacing, or we can put a leadless pacemaker for that patient from the femoral vein. So I think these are indications of pacing. First and foremost indication is advanced second or third degree AV block, which we had seen in our example. Secondly, sinus node dysfunction or sinus node bradycardia, post-operative complete heart block, which is not expected to resolve. Congenital AV block with a wide QRS escape. So all babies born with a congenital AV block will not need a pacemaker immediately. We will watch them over the next few days. We will see what is the QRS morphology. We will see what is the heart rate, the average heart rate, and whether there is presence of ventricular dilation, ventricular dysfunction, whether there is any other ectopy coming in, whether there is failure to thrive and developmental delay in terms of gross motor developmental delay. All these things will decide whether we have to put a pacemaker, because pacemaker, putting a pacemaker itself is like another inviting another disease in itself, because it needs a lot of follow up. We need to change the generator after 7 to 10 years. Mostly in children, we have to change it earlier because the children have a higher heart rate, and the pacemaker battery gets depleted earlier in children. Then congenital third degree AV block can, in an infant with ventricular heart rate less than 55, if it's a normal heart rate, normal heart or structurally normal heart, and if the infant has a congenital heart problem, then with the average ventricular rate less than 70 or less than 60, we are doing the AV, we are doing the pacemakers. Then in certain myopathies or inflammations, acquired heart block, and we also we also do pacemakers in a long QT syndrome with extreme bradycardia and conduction disorder to take care of the heart rate and stabilize the heart rate. So that brings us to end of my talk, and I'm happy to answer any queries.
Thank you. Thank you, Atul. I request Dr. Maitri and Dr. Vikas to make any important point or comment about
Yeah,
Maitri.
Dr. Atul, yeah, that was a fascinating talk, covering everything. I just wanted to know, like, in complete heart block, SSM, anti-SSM mediated, initially we are putting epicardial pacemaker. By which age we can expect his bundle pacing or LVBA pacing to so that it becomes more synchronous in your practical
Mm.
experience? From which age group have you put these better synchronized pacemakers?
Mm. Yeah, that's what number one, we try to delay the first pacemaker as much as possible, as much as tolerated by the child. We will not intervene immediately. So if he is fulfilling those criteria only, then we will put the first pacemaker, that is the epicardial pacemaker. And most of these children can take the next pacemaker as probably by 5 to 6 years. And that time, if the child is more than around 20 kilos, we can put we can put a lead in the ventricle and give them a ventricular his bundle pacing. We may not be able to do a DDD or a dual chamber pacemaker, but we can put a ventricular not his bundle left bundle branch lead, and thus we will get a ventricular narrow complex rhythm. In the third pacemaker, once this pacemaker gets depleted, when we change the PG, we can also add on one more lead to the atria and then convert it to DDD. That will be around 10 to 12 years of age.
And that is very interesting because we are really struggling with many congenital heart blocks who are really pacemaker dependent. I
Yes.
mean, who are on ventilator and in very bad shapes. And many people have told them that pacemaker itself will kill the child. So because of it will worsen the ventricular dysfunction. So it was a question like with the advanced technologies, I don't think epicardial pacemaker in very symptomatic heart block. I mean, I think what you said, 6 years and then 10 years, you
Mm.
have a fair chance of
We have a
remodeling
fair
the heart
chance. Yeah,
also.
yeah, yeah. Because see, first of all, it lies with the surgeon. The first success of the first case, that they would have to find one spot which has the narrowest of the QRS that he can get, probably, which is LV septum, and probably at LV apex or LV apical septum is probably the narrowest QRS he can get from the epicardial. But they will put on the RV, and putting on
Yeah,
the RV results in the LBB, and LBB is one of the
correct.
risk factors for the dysynchrony. So our main aim should be to get rid of the LBB by pacing the LBB. So LBB left bundle should be the first thing to be paced rather than anything else, and then you get a good synchrony. Um, uh, just having a good left ventricle pacing at 80 70 throughout the day is good enough with most of the kids. At a narrow complex, they won't develop the pacemaker induced cardiomyopathy. But in future, then we have to put in a atrial lead. Now, in our center, we have put atrial leads also as a because if the vein got thrombosed in the first sitting, then we have put a atrial lead as a epicardial atrial lead and connected to the endocardial and connected to the same pacemaker on the left side infraclavicular fossa. So that has been done with the help of a surgeon, but that is only in those cases. But if we have good access in the subclavian, we can put the two leads when the child grows up, maybe around uh, 12 years or sometimes 14 years.
That's a very valuable information. Thank you.
Okay, so thank you, Atul, covering arrhythmia in detail, means all type of arrhythmias, Brady and tachyarrhythmias, everything. And thank you, Maitri, for your inputs, and thank you everybody for attending these webinars. There are questions about when we are going to repeat this sort of e-learning program again. Obviously, we will keep on doing, and we'll share the information in the group. These are important lecture for all of us because all of us are learning from different perspective point of view, like and especially ECG arrhythmia. It is important to reach to the pediatrician, and a pediatrician need to become very comfortable with the ECGs, like adult medicine guys are there. So, and that only we have to reach to the pediatrician to make it more visible, more easy to with the rhythm, with simple ECG, with arrhythmias, with congenital heart defect ECG. But we have to use ECG more frequently, like PJRT, that dilated cardiomyopathy type of patients. They just keep on struggling with these, and they don't get much benefit by the antiarrhythmic drugs. And obviously, it is EP study and RF ablation is the answer if it can be done. So these are the cases which we need to define and that change the life of these kids. I am following two kids, two girls, one 8-year, one 10-year, for a few years diagnosed to have dilated cardiomyopathy, recently seen. It looks like very simple sinus tachycardia and 140, 150 heart rate for this age group. But the axis, P wave axis is abnormal. So that says that we are not dealing with the sinus tachycardia. Means it's some sort of arrhythmia is going on. So these are the simple clues we have to catch from the ECG. That's why access is important, rate is important, 1:1 conduction or what type of conduction it is going on. Everything is important. So we have to read it sequentially. Every segment, every interval which is defined in the ECG, once you start reading the ECG, you will you need hardly any second to get the information. But initially, some time is required to get used to for this, to add this important investigation to your list. So thank you, everybody, and we'll share the presentation with all of you in the group, and we'll organize another part 2 of this e-learning program, and the information will be shared to you from the UPAOP. And thank you, UPAOP, for allowing us to connect with all the pediatrician, all the students in Uttar Pradesh, so we can reach to each and every segment of the medical colleges in our state. So thank you, everybody. And thank you all the faculties for being so always ready to be part of these teaching program. Thank you.
I like to take this use this platform to convey one message. I was conversing with Dr. Maulisha from US, and she is a
Yeah.
pediatric EP person. She was saying that in her center, she's doing a lot of these WPW ablation, but in the US, the adult EP people do not do WPW at all because it is dealt with at pediatric level itself. So this is something we should target at our point so that our adult colleagues do more so their VT and AF ablations, which they are more, faced or we need their experience to do that. And ablation for the pediatric age group could be left with us. So I just use this
Yeah.
to convey to all our pediatrician friends also to
Mhm.
identify any WPW and send them for ablation whenever they find.
Yes, thank you. And as continuation of this e-learning program only on 21st of December in Aligarh, we are doing the physical activity, that is the physical echocardiography workshop, hands-on on that. So all candidates who are registered into this are automatically being registered for that, but just need to fill the form to say you are coming for the event so that we have to be ready for the number of people we are going to get. So be there. So request you all of you, because whatever we have learned here, we can revise it at that particular day. And thank you again. Thank you, Atul. Thank you, Maitri. And thank you,
Thanks.
UPAOP. Yeah, thank you. Thank you, everybody.